Hello, everyone. Welcome back to Neurospicy Nursing. Today, we're going over the pediatric endocrine system and or endocrine disorders. If there's bad audio, I'm sorry. I'm still in the process of moving, so once all of that stuff gets set up, we should be back to where we were while I was at home, or our old house, I guess. You guys know what I'm trying to say. All right. So, getting on into it. The endocrine system is all of the glands, the hormones, um, and all of that fun stuff. But it's basically a messaging network. So your hormones are like little texts that are being sent, and then the glands is like your your phone receiving the text. The hypothalamus is the master regulator and is constantly reading the room. So it reads for temperature, stress, hunger, and it adjusts hormones accordingly. Your pituitary is like the boss gland, and it releases tropic hormones that tell other glands to do what they need to do. The thyroid manages your metabolism, growth, and thermoregulation. Parathyroid helps keep calcium and phosphate balanced. Your adrenal glands handle cortisol, aldosterone, and catecholamines. So it's all of the stress and fluid balance hormones. Your pancreas regulates glucose and insulin, as well as glucagon, and the gonads control the sexual development and puberty. So every disorder that we're talking about today is a disruption of one of these pathways. All right, so the first one, diabetes mellitus. Insulin's job is pretty simple. It unlocks the cell so that glucose can get inside and then it can be used for energy. If insulin is missing or ineffective, glucose is going to stay in the bloodstream, the cells are going to start to starve, and the body breaks down fat and muscles, which is going to then produce ketones. Type 1 diabetes is autoimmune. The body has destroyed its own pancreatic beta cells, so insulin production drops to absolutely zilch, zero. And these kids are going to need lifelong insulin therapy versus in type 2 diabetes, they have an insulin resistance as well as inadequate insulin production. It's strongly tied to obesity, inactivity, dyslipidemia, and hypertension as well. And as nurses, we are going to make sure that we're teaching how to monitor their glucose, how to administer insulin, carb counting, and then we're going to tailor all of that to the child's developmental stage as well. If we need child life to help us, then that's another resource that we can use. But we're also going to collaborate with endocrinology, diabetes educators, and nutritionists. Also, if they're really young, being in a support group or something like that with another kid with diabetes is also helpful. Hypoglycemia happens when insulin is too high, meals are missed, or they have an increase in activity. It's when the glucose drops below 60 because your brain relies on glucose and the symptoms show up pretty fast. Signs are going to include hunger, irritability, anxiety, cool, clammy skin, tachycardia, slurred speech, confusion, and in super severe cases, seizures and or coma. Nursing care is the 15-15 rule where we give 15 grams of fast carbs, so we recheck in 15 minutes, and we're going to repeat that until they're above 80 milligrams per deciliter. And we're going to also explain the complex carb and protein diet. And if they can't swallow any pills, we're going to give, or pills, not pills, but like the gel. They can do the tablets as well. But if they can't chew tablets or swallow the glucose gel because let's say they're incapacitated, we don't want to put anything in their mouth, we can give them glucagon either IM or IN. And we also need to make sure if it was because we gave too much insulin and we review any of the dosing errors. Okay, so hyperglycemia and DKA. Hyperglycemia is a blood glucose of over 250. Your body starts to compensate by dumping the glucose into the urine. That's called osmotic diuresis, and the child is going to become severely dehydrated. In DKA, insulin deficiency is going to become severe. The glucose is going to skyrocket greater than 330 milligrams per deciliter. They will have ketones, and they'll also have metabolic acidosis. The potassium shift is also going to happen because will, it kind of helps insulin helps potassium shift. Sorry, that was really hard for me to say. Insulin helps potassium shift. So without it, it's going to shift and they'll become out of the cells and they'll become hyperkalemic. And then they'll become hypokalemic once they start getting their insulin treatment. Clinical signs are going to include fruity breath, Kussmaul breathing, nausea, vomiting, abdominal pain, weakness, confusion, and or poor perfusion. For the nursing care of DKA, we're trying to manage their fluids and their insulin drip. We're doing hourly glucose checks, and we have to make sure that we are closely monitoring their electrolytes, especially their potassium, because insulin is going to cause it to shift inside of the cells. The other thing that we have to make sure that we're doing is close cardiac monitoring as well. I did neuro checks on here. I did forget to mention close cardiac checks because, again, the potassium. And then we're going to teach them about the sick day rules because illness is going to increase glucose, even when kids aren't eating, just because of the stress that sickness does to their body. All right, so insulin therapy. There are lots of different types of insulin, like Lispro, Aspart, regular insulin, NPH, and long-acting. Nursing care is going to include sub-Q admission, either via a syringe, a pen, or a pump. Pumps are normally paired with CGMs, and they kind of act like an artificial pancreas. But remember that sometimes those aren't always perfect, so you may still need to do a finger stick. But CGMs also can lag up to 15 minutes behind the blood glucose. We also need to teach the patient that they need to rotate their sites and monitor their skin integrity. Type 2 diabetes in kids is driven by insulin resistance from adiposity, and the pancreas at this point is going to be overworked until it just completely fatigues. One of the things that's kind of important for this is social determinants, so foods, um, specifically if they live in a food desert, unsafe neighborhoods, limited access to healthy foods all impact the management of diabetes. And then there's other clinical indicators like their BMI above the 85th percentile, um, dyslipidemia, hypertension, PCOS, and then an elevated A1C. And nursing care is all about teaching them lifestyle changes, how to take their metformin, um, and making sure they're coming back for follow-up as well. And we need to do the teach back. And this is another instance where having them with a group of people that have the same illness as them could be helpful to see how people their age have dealt with being told you have diabetes, like a support group. All right, growth hormone deficiency. This is when your pituitary gland isn't producing enough growth hormone, and now your bone growth is going to slow, your plates are going to mature late, and your bone age is younger than your chronological age. These kids have a height that's below the 5th percentile. They have their teeth grow in late as well. They have delayed puberty and an increase insulin sensitivity. We are going to make sure that we prep them for their testing of their growth hormone. They have to be NPO when that's being done, and they also need to have very limited activity. If they do have GHD, then we're going to give somatropin at bedtime. It's sub-Q. We're going to monitor for any increased ICP, edema, arthralgia, and gynecomastia. And then we're going to track their growth chart pretty closely and then make sure that we're supporting their body image, especially if they're a teenager where it's really, really hard. All right, precocious puberty is early puberty. So the other one was late puberty. This is early puberty. And it's because they have an excess of LH and FSH, causing sex hormones to release early, which then causes a premature closure of their growth plates, and they end up being really short, which is kind of unfair because I don't have this and I'm extraordinarily short, but you know, it is what it is. You guys know what I mean. Um, so some causes are hypothalamic tumors, brain injury, congenital adrenal hyperplasia, ovarian or testicular tumors, and sometimes either even exogenous hormone exposure. The treatment is going to be GnRH antagonists, like the implant or the depot. And we're going to monitor their growth closely, educate them on their medication schedules, all of the different side effects. We're going to coordinate with an endocrinologist. If they have a tumor, they need to see an oncologist or radiologist, or I think it's called a radio oncologist, where they do both. Um, and then, of course, you need to discuss with the patient how it's affecting them psychosocially. Okay, diabetes insipidus. We've talked about it a little bit in the past, like through med-surg and whatnot. But DI is either a failure of the posterior pituitary gland to release ADH or the kidneys failing to respond to ADH. So the result is instead massive amounts of dilute urine, dehydration, and hypernatremia. Signs are obviously going to include polyuria and polydipsia. That's really why it's called diabetes, because both of them had it. But until we figured out there was a difference, that's how we came up with DI and diabetes mellitus. But originally, polyuria and polydipsia, it makes sense when you think about diabetes that they have the same sign. The only thing you're missing here is the polyphagia, which you see in diabetes mellitus. But they will also have low urine specific gravity, and they'll have hypernatremia because of all of that fluid, which is going to cause an altered mental status. Nursing care is daily weights, strict eyes and nose, urine osmolality monitoring. They get DDAVP as a medication, and they'll also need seizure precautions because of that low sodium. And then we are going to teach their parents to recognize sodium-related neuro changes. SIADH is the opposite problem where they have too much ADH. Water is retained, sodium is going to drop, and then that urine becomes super concentrated. There's a bunch of different causes. One of them could be from like a central nervous system infection, if they have a tumor, any trauma, prematurity, sometimes even chemotherapy. Signs include low sodium levels because it's diluted, decreased urine output, edema, because decreased urine output is because the excess ADH, edema, there's a lot of water, nausea, vomiting, confusion, and seizure risk. Confusion and seizure risk is from the low sodium levels. Fluid restrictions is something that we're going to do here, as well as daily weights and strict eyes and nose. They have to avoid alcohol-based mouthwash. And when they're really, really thirsty, sucking on a hard candy is something that's suggested that we teach, as long as it's appropriate. If they're too little to be putting hard candy in their mouth, and don't give it to them, but keep that in mind. And then they're going to get medications like vasopressin or corticosteroids to help with the excess ADH. And then last slide, we're going to reinforce all of that education with both the child, as long as they're old enough to kind of understand, and the caregivers. We also need to identify any safety concerns, um, as well as any barriers to access. Like, do they have transportation to get to all these appointments that they have to go to? Do they have access to healthier foods? Do they have insurance? Do they have support from their school? Um, do they have friends even is something, especially growing up, like not having any friends and you're going through something like this, it takes a toll on you. And then, um, family-wise, connecting them to any resources that they need, like a diabetes educator, a nutritionist, social work, the school nurse, etc. That's what we need to do. These are my resources, and that's all I have for you guys. I have another lecture coming out soon on neuro. Um, so yeah, thank you guys and have a great day. Bye.